Greetings. This is Graham Warren, working with you on the hip-hop case. This case was co-authored with Julie Katie Ray and Dr. Harpal Kanuja. He also goes by Paul. Paul is the director of orthopedic surgery at Johns Hopkins School of Medicine. So this is a case which is only going to admit simulation as an analytic strategy because it has an extended warm-up and warm-down phase. There's insufficient steady-state operation to allow us to use queuing. So the idea that I'd like to pursue here is to have sort of screen you from shield you from the possibility of extended time on any logic models. So the idea is to introduce the case in this clip, walk through the model construction. I made a mistake in the earlier edition. I, for some reason, thought that an anesthesiologist didn't need to be around during the surgery, but of course that's not true. So I had to change the model a little bit, and I'll detail what that change is. This case involves a fictitious hospital system with 4 ORs in which knee and hip replacements are done. It's a high volume environment. The rate that you're going to see for these surgeries is about 4 surgeries per day with an associated flow time as we're going to measure. And this is a game of inches. This is a well-studied problem. There are many peer-reviewed articles, journal articles that have been written on this workflow. And certainly many consultants have leaned in on these issues. So the idea here is to see if there's anything at all that we can bring to the table. And the performance delta may be much smaller than what we saw in the ACG case. Just recognize that. So there are 2 key KPIs. One is the number of surgeries done. These surgeries, produce about 14 to 16,000 in revenue. Doing an extra surgery per day, is financially meaningful, and that's our first KPI. There's a 9.5-hour day. The surgery started at 7:30 in the morning. At least the patients show up at 7:30, and the end of the day is 5 p.m. Anybody who needs to be closed up and finished up will be done, but the idea is to sort of pace the arrivals so that it's possible to wrap up plus or minus 5 p.m. There's some information we've obtained and incorporated here from the American Joint Replacement Registry, AJRR. There's a 2021 report that we've borrowed from, and that information shows you breakouts by age, gender, and race. So you can explore, those markers and the incidence rates for hip and knee replacements for those categories. These categories are protected, and differentiating or structuring the workflow to try and leverage or exclude some of these categories would be problematic. There's a paper by Paul Kanuja from 2019, and of course his co-authors, in which he shows that BMI is a meaningful determinant of the patient's BMI, body mass index, is a meaningful determinant of the median time to complete one of these surgeries. Both the knee and the hip replacements are being lumped together as a single kind of proxy surgery. And these results are given for sort of that mix of hip and knee replacements. And so you can see that the lighter the patient, generally speaking, there's a small difference here between normal and overweight, with overweight being slightly lower. That just could be, sample variation. But you can see that for obese and morbidly obese, the numbers get quite a bit higher. And it's also true that the variance increases in general as the time goes up, as the BMI increases. There's another possibility that Paul Knuja and his co-authors investigated, and that is that ASA physical status is a determinant, and that was found to be not significantly significant. Not statistically significant, rather. All right, so the surgical process in a nutshell is laid out. Okay, so the actual percentage of the surgeries that are done at Hipkins Hospital, our fictional hospital, is shown here. The mean times come from Paul Knuja's article, and then Paul oversaw this statement of standard deviations for the service time. We've got the workflow outlined here. There's a registration step. Then there are two steps, pre-op prep and anesthesia evaluation and consent. This is where the patient actually, I guess, gets the anesthesia. I'm lumping these two together, and I'm saying that the anesthesiologist needs to be involved here. So I'm taking this as a mean of 25 minutes, and there's an adjusted standard deviation because there's some cancellation effect when you add two standard deviations together. All of our processing times here are assumed to be normal. The procedure times, this 100.71 is a calculation from Paul's paper and his co-authors, of course. Standard deviation is using the variance of the sum of random variables formula. Then there's a turnover. Now this number, this mean here is pre-pandemic. And in the actual simulation, I've changed it to 40 because there has been significant slippage because there's high turnover in that role. The room turnover is executed by EVS staff. I believe it's environmental services. And the significant training is involved. Once the folks get trained and have some experience, those times come down. But given the labor market as it is now, new folks are hired, they get trained, and just as they start to show better performance, they move on to other roles, and then you reset and you have to start training again. So those numbers are, because of the pandemic, much higher, and I've shown them to be 40. So there's possible reductions that available there in that mean processing time to turn over the room and set up and restock the instrumentation. But it's not clear that we have that much control over that because of the wage rates as they are and market conditions. We're not going to simulate the recovery or the discharge of patients. We're only going to be interested in arrival, registration, anesthesia, surgery, and then the cleaning of the room. So sort of the production part of the process. In fact, patients will go on to around 2 hours of recovery in the PACU. A small fraction will go on to stay overnight. Most go home. And then an even smaller fraction stay longer than one night. The lenses that we used to investigate our other case, does utilization matter, does pooling matter, does variance hurt, and does psychology matter, are going to be used to guide our creation of scenarios. Some scenarios are not going to be available to us. For example, pooling of either anesthesiologists or surgeons is probably not something that can be achieved because there's an expectation on the part of patients that they will be operated on by a surgeon that they have seen during an office visit. So it's not a case that surgeons and anesthesiologists can be randomly assigned to patients. I'm also looking for answers to some of these supplementary questions. There are some papers listed here. You can use Google Scholar to pull up any of these papers. Just copy and paste these into Google Scholar, and you should be able to at least pull up the paper and see the abstract to see what is available there. Standardization, is a possibility, but as I've mentioned before, it's sort of on a request basis with the surgeons rather than a mandate because of their agility, their career agility. You can't press them too hard, apparently. Okay, so that is a sort of a light introduction to the case. Our next clip is going to look at the construction of the model and to try and break out all the little process flow blocks, and explain that. And then we're going to, in the third clip, look at the base case, that is the current setup, and then we will do, and I'll try and run 3 replicates of all the scenarios that we consider, and then we'll start thinking about what can change and start assessing if there's any performance delta on those.